Hello, everyone. Thank you so much for joining today. We're going to get started in just a couple of minutes to give folks some time to join. Thank you. Hello, everyone. Thank you so much for joining. My name is Lauren Berner, and I'm Project Manager at the National Healthcare for the Homeless Council. Today, our session is on multi-system coordination, building and maintaining a coordinated provider community. We have two great presenters with us today who are going to talk about their work in Boston and Albuquerque. So I am very excited for our content today. If you aren't familiar with CSH, who is hosting this session, they are a national nonprofit with the mission to advance housing solutions that deliver three powerful outcomes: improving the lives of vulnerable people, maximizing public and private resources, and building a strong, healthy community across the country. CSH is a technical assistance provider for both HUD and the Health Resources and Services Administration, or HRSA, part of the Department of Health and Human Services. CSH, as a HRSA technical assistance provider, has a lot of different programs running, including this webinar on multi-system coordination, as well as direct technical assistance to health centers and setting up regional trainings and peer-to-peer learning. The specific focus of this project is to build partnerships that can address the needs of those in our communities with limited access to primary care and other health services, as well as those who frequently use emergency and crisis systems. As I mentioned, CSH is working closely with the National Healthcare for the Homeless Council on this work. Our speakers for today are myself. Again, I'm Lauren Berner from the National Healthcare for the Homeless Council. We also have Mary Takik from the Boston Healthcare for the Homeless. She's the Senior Director of Health Policy. And we also have Anita Cordova, the Director of Development, Planning, and Evaluation at Albuquerque Healthcare for the Homeless. To quickly review our agenda for today, I'm going to start by giving a brief overview of multi-system coordination. And then we'll hear from Mary and Anita. We'll also have some time for facilitated discussion where they'll respond to some questions that we discussed in advance. And then we'll definitely open it up to Q&A. So if you have any questions, please type them into the chat box. You'll see the chat icon at the top right corner. And we'll get to those at the end. For folks wondering about the materials for this session, we will be sending out a copy of the slide deck as well as the recording for this session once we've concluded today. So to jump in, just a quick overview of multi-system coordination. So I think most of us on the line would agree that the folks that we serve are experiencing complex health and social needs. So addressing those needs is especially difficult if we're trying to navigate health and social systems that aren't typically coordinated and are often very fragmented. And that really has a negative result on the folks we're trying to serve who are navigating these systems. So they're complicated to manage for anybody, but they're really difficult if you're also experiencing homelessness or have unmet behavioral health conditions, or you're experiencing trauma, and if you've had just poor experience in the health system or in other systems in general. The goal of coordinating care across multiple systems is to just move away from having an individual navigate all of these different complex sets of systems and move towards providing care that's coordinated at all levels, from impacting social needs that impact folks' health outcomes like housing, as well as looking at how we can incorporate behavioral health and other healthcare needs. So if we kind of compare this image with the last chart, this is closer to what coordination looks like. So it accounts for issues like transportation and incorporates partnerships and strong partnerships across systems, especially looking at things like partnering with the Department of Social Services and recognizing that things like transportation might be critical for high-quality healthcare delivery. And this really keeps the patient's needs at the center here, and the programs are designed to work together to meet the needs of the patient. There's no perfect model for this coordination, and nobody really has it completely figured out, but we do know that we can't solve problems in silos. So improving healthcare is going to require partnerships across agencies, teams, and sectors to make sure that we're meeting the needs of our consumers. So who are the partners involved? Each community is going to look a little bit different based on what you have available, but effective partnerships like the ones you'll hear about today really look across multiple sectors and can improve health and can involve health centers, hospitals, insurance providers, housing and social service providers, and the criminal justice system. So folks who might work in probation or parole, jails and prisons, the court system could also add in legal aid or assistance to that list as well. To kind of frame the concept of care coordination and systems coordination, I wanted to just kind of run through a couple of key components of care coordination. One is the ability to share data. It really gives you the opportunity to communicate with your partners and have a holistic view of how the folks you're serving are interacting with different service providers in your community. Having a defined team structure and defined roles across the different sectors, really helping to understand what your role is within that coordinated system and clearly define the expectations for you and your partners can really help that process run more smoothly. Coordinated care planning, so thinking about what the individual's needs are, working with your partners to help coordinate how you can address those needs, and of course involving the patient themselves in the goal setting. And then building those strong partnerships at all levels, so making sure that you not only have the on-the-ground staff on board, but also organizational leadership. And so really thinking about how you can kind of build that system, and that's what we're going to talk more about today. I do want to note that we recommend using trauma-informed care frameworks as well as harm reduction kind of as the basis for how you kind of design some of your interventions while you're coordinating. So thinking about the different systems that might be involved and kind of what their priorities might be, I wanted to just start by focusing in on 3 specific systems and recognizing that this might look different in your community based on who you can involve, but some of the key players and their priorities kind of frame how you might implement this. So in the health system, we can have health centers and other primary care providers, hospitals, health insurance providers, can loop in behavioral health care, substance use providers into this as well. And their priorities might include improving the health of folks by ensuring that they're connected to primary care, maybe reducing unnecessary hospitalizations or addressing the social determinants of health, making sure that folks are connected to appropriate services and resources, ensuring that folks just have access to what they need to take care of their own health, and there's a variety of other priorities here. On the housing side, we have the continuum of care, housing authorities, housing providers themselves, supportive service providers, and their priorities might include getting the most vulnerable folks into appropriate housing, engaging residents in voluntary supportive services, ensuring folks are stabilized in their housing, and helping folks remain independently housed as long as possible. On the justice side, we again may have the police department, probation and parole, jails and prisons, the court system, legal assistance providers, and their priorities might be reducing police encounters, especially for things that might be related to housing status, like loitering, reducing recidivism, ensuring connection to necessary services upon release from jails or prisons, like health and housing. And so these systems can really benefit from working with each other, and their priorities can be addressed by these partnerships. So for health centers, multi-system coordination can provide the opportunity to improve care coordination in a way that addresses the holistic and wraparound needs of their patients. So really addressing those social determinants of health and connecting to other organizations that provide necessary services rather than trying to figure out how to build that capacity yourself. It also allows for a broader reach, as folks that might be interacting with the housing system or the justice system might not already be engaged in healthcare. So leveraging those relationships and building on your partnerships to help build trust can improve outreach and engagement strategies. For housing providers, the health and justice sectors can really assist with outreach. So again, the justice system or health system might be encountering folks who aren't connected to the community's housing resources. And these other partners can really help to identify folks who might be eligible for services. Health centers and other healthcare providers also are able to provide those necessary primary and behavioral healthcare services that can help folks remain stably housed and healthy, working to prevent some health issues that may compromise someone's ability to remain independently housed. And for the justice system, the connection to housing can really reduce interactions with police for crimes related to housing status, and can also provide a sense of stability that can help to reduce recidivism. The health sector can also help to ensure that there's a smooth transition of care upon release, so making sure that folks have access to medications as well as primary care and behavioral health care. And then both of those sectors work with various other partners to kind of connect to other social services, and all of this can help to improve someone's stability and reduce their interactions with the justice system as a whole. At this point, I want to pass it over to Mary to provide a bit of an overview of some of the work that they're doing in Boston.
Hi, thank you very much, Lauren. I'm hoping you can hear me.
Yes, I can, and you should
Great.
be for now.
Perfect. Thanks, everyone, for joining. I'm going to be talking about Boston Healthcare for the homeless experience in developing a multi-system care model in a very rapidly changing healthcare environment. I'm going to first start out by describing a little bit about us, and then about a project that began as a pilot and now growing into a full-fledged program in our experience, all in under 10 minutes, I hope. And Lauren, I might need some help advancing slides.
Should be able to click the arrow up at the top there.
Okay. All right. Oop. Yeah, I'm probably going to need some help if you don't mind.
Don't mind at all.
Let me first begin by just telling you a little bit about us. Boston Healthcare for the Homeless was one of the original healthcare for the homeless programs. We were founded 33 years ago, and we are the largest healthcare for the homeless program of its kind in the U.S. We are situated in the state of Massachusetts, and Massachusetts is a small state, but we are a healthy state. We have the highest rate of health insurance coverage in the country at 97.5%. But as one of the ramifications of having everyone under the roof, on slide 3, we also have the highest per capita health care cost in the country. We're only second to Alaska with the highest amount of healthcare expenses per person at $11,000 per person. So moving on to slide 4, when a state begins to look at how to stem the rising cost of healthcare, they start to look at looking at populations like ours seems to attract a whole lot of attention. We have a really high costly population, no doubt. Many of your populations look a whole lot like us, a high rate of mental illness, substance use, co-occurring conditions, on top of the unmet social determinants of health needs. So our patients are costly. We have a disease burden is almost, our DXCG score is 3.8, so almost 4. And no doubt our healthcare expenses are 4 times the cost of healthcare for other Mass Health or Medicaid members. So over $2,000 per member per month when the average cost is about $568. High rates of ED and hospitalizations, and as with many of these high-cost population, a lot of our high costs rest with a small cohort of patients, the top 10% accounting for the top 50% of our costs. So we have in this rapidly changing delivery system, our population tends to be the population that people want us to come up with solutions. So if we go to the next slide, Mass Health or Medicaid's idea of trying to rein in healthcare costs is to organize the healthcare system into accountable care organizations. Our organization saw this coming. We knew that the ACO talks had been going on for years. We have had a long history of collaboration with 9 other organizations that does homeless health services of a variety, a wide range from health to housing to social services and shelter. Those kinds of services, we have been meeting for a number of years and all had this shared interest of trying to stay relevant in this ACO space. I mean, ACO has this history of trying to build within, I can build a care management system or build other kinds of systems and not have to partner with other community-based organizations. We wanted to get ahead of that, so we started to have discussions early on. We talked about how we were stronger together and that with the capacity that all of our organizations bring, that an ACO would have a hard time replicating the work we did. We began by getting some small but important grants from the states to help us begin to develop the infrastructure we needed to collaborate. We were able to get a state infrastructure and capacity building grant that allowed us to basically hire lawyers in order to develop a legal agreement that allowed us to share data across our multi-sector systems. We also had a strong and important linkage to the city of Boston, which offered an existing data platform that all of us use in some ways that we could leverage as a tool to share information across our organizations. But the real catalyst for now testing this collaboration and testing our partnerships was a small grant that or not so small, but a grant that we received from the Massachusetts Health Policy Commission that allowed us to begin to pilot what we were learning on a small population of high-cost, high-needs population. So moving on to slide 6, this basically the Health Policy Commission grant gave us our training wheels to begin to put in place the system we needed to share information electronically, and then also develop communication pathways so that we can better integrate care. It was a 2-year, $750,000 grant. Basically, half of the grant went to developing that core infrastructure, and the other half went to providing per member per month payments to our partners. Our goal was to reduce the utilization of the 60 highest cost, highest needs Medicaid homeless individuals in the city of Boston. We move on to slide 7. Our social determinants of health coordinated care hub, as we call it, is basically a super utilizer hub. And I know there's lots of super utilizer kinds of initiatives across the U.S., but what I wanted to highlight were a couple of things in red. First, what's different about our project is that we had that payment, that grant payment, and we flowed it out to our partners so that we gave them the ability to hire their own staff. We would provide the payment, and then we would provide the nurse that would connect them to the program. So that was really key to the integration. We also had the shared care management platform. As I mentioned, it was, we worked off the City of Boston Department of Neighborhood Development platform that manages the homeless, the HMIS system, and then we added new functionality to that. In this functionality, we're able to share a whole lot of data, including PHI and housing data and other kinds of information to help inform care. We share care plans. So this care plan lives on this platform, and the care plans are developed in concert with the case managers that are nested in our partner organizations, with the patient and with the primary care teams, so that we're actually doing joint training and case conferencing and really trying to develop that integrated model. If we go on to the next slide, I just kind of like to show this slide. I can't really explain it all. It's our IT staff did this slide, but what I did want to show you is that large purple box, that Windows to the Warehouse, that's the City of Boston's HMIS platform. And what they did is they provide us a space within that Windows to the Warehouse, the SDH hub, that we could carve out, we control permission to get people into the space. So we only allow people, case managers or staff that are connected to the pilot, to see all this data that comes in from a variety of sources, including HMIS, our EHR, care management software, and other claims data and other data support. So that's what the functionality of the hub. If you move on to the next slide, I'm just going to go really quickly through this, but I just wanted to show you the richness of the data that we're sharing, because I mean, this integration requires a great deal of work, and the data helps support this work. So we get claims data from Medicaid, and so that we can feed this data, and this is an actual care record in the hub, showing the care case management about recent ED visits, even the kinds of ED visits we have. In the lower right corner, we have a self-sufficiency matrix that is taken every 6 months to measure how we're meeting a patient's social determinants of health needs. We have instant feedback on housing status, bed stays, that kind of thing. If we move on to the next slide, you can see that we have a place. This is the care management software that City of Boston supplied to all of our partners as well. You can click on case management notes so you can find out what, how often that case manager is seeing the patient, how often, what's the quality of that visit. We have team contact information for the team members and the goals for the patient in there as well. So you can see we do have a lot of information that we share. So moving on to slide 11, so is this working? That's what everybody wants to know. Are we saving money? Are we providing better care? And what I can say is it's kind of early to tell. We have also a very small population of 60. It's all pointing in the right directions. We are reducing some utilization, so we think it is. If you go to the next slide, we definitely know we're moving in the right direction on housing. We are getting more people housed. We're pooling our resources, and it's great to be able to leverage our partners' access to some housing stock that our patients seem to get teed up a little faster for, and for other kinds of services. And so if we move on to slide 13, I just wanted to kind of give you an idea of what's happening ahead. It's actually in 5 weeks. And in this ACO environment, ACOs are required to contract with community-based organizations to provide a complex care management services. And our consortium has successfully bidded to be a community partner. So we are going to be ramping up from 60 patients that we have now to 1,000 patients by the end of the year because we have received this contract. We have two flows, two funding flows that will be supporting this work. One for the actual care coordination payments that will again flow out to our partners, case managers, and then we have that infrastructure payment to continue to improve our IT systems and to develop reporting, because what the big change is now we'll be held accountable for what we're doing. So having that infrastructure in place is critically important for us to be able to participate in this accountability kind of framework and kind of system. And then as we move on to slide 14, these are the kinds of metrics that we'll be held accountable for. I'll just have you quickly eyeball that. And we have questions, I'd be happy to answer more. But if you kind of look at the bottom of that slide, it's all about reducing ED, hospital readmissions, transitions of care. We feel like we're in a very good place, maybe have a head start on other community partners who have bid to contract with ACOs. And then finally, I just wanted to end that, this is what we've learned so far, with our couple of years that we've been meeting together as consortium. The data sharing is absolutely a game changer. That data platform has really began the conversation, putting data, clinical data in front of non-clinical case managers has really been powerful. The thing is, though, we do a really good job case managing them, but sometimes there's no place to case manage them to. We still have a logjam with a number of addiction beds and, of course, affordable housing. So there are some costs that we will never be able to control because there are no beds. Places that are pharmaceutical costs is actually our #1 cost center for all our patients, something that we were surprised to learn. And we are managing people, many at the end of their lives. We've had 6 patients that have died to date because they're they're in end-stage kinds of diseases, or the complexity of their disease has made their lives extremely short. But I think the take-home message here is that integration, it is definitely hard work. It would be so easier if we did this alone, but this is really the right path to go. It's really broadened our reach into the kinds of services that we can provide our patients, and actually has made us a player in this accountable care system being taken on by the state of Massachusetts and their Medicaid program. That's all I've got.
Thanks so much, Mary. Next up, we have Anita from Albuquerque.
Hi, can you hear me?
Yes, we can.
Hi, well, thank you, Lauren. I'm very excited to be here and talk with you all about multi-systems coordination. Following on Boston's footsteps, I can tell you our experience will not be as prominent, but we have a large variety of experiences. However, we are often not the lead, which is interesting. We participate as willing players, early planners, and developers of the multi-system coordinations. So we won't have you won't see all the beautiful slides and graphs on this one, but lots of good information I hope to leave you all with. To start with, we are one of the original, as is Boston Healthcare for the Homeless, freestanding healthcare for the homeless providers. So that just means we get asked to sit at a lot of tables without a lot of resources, which is okay. We're okay to play that role. We look at it as an opportunity to amplify our model within our own organization and across the community, which really does happen in these multi-system coordinations, and I'll show you a little bit of those examples as we go. I won't go through our mission, but I will talk a little bit about our vision, which many of us on the call today likely share. Our vision is to live in a world that is just and without homelessness, and why that is important is because every time we go to a table, whether in the pre-planning phases, the implementation, or the development phase, we are always holding this goal to do what we can to make sure that we're eradicating homelessness and not just helping people experiencing homelessness be more comfortable. So that's both a very exciting role to play, but can sometimes frustrate some of our systems coordinating partners as they're not always looking to that larger social justice aim. I won't talk about this a lot, but as you know, Healthcare for the Homeless hallmarks, right, are our outreach, our comprehensive integration, access, person-centered care, no wrong door approach, harm reduction, and of course trauma-informed care, which is not on this slide. Those are always the things along with our vision that we bring to the table in the multi-systems coordination that are exciting to others as they think about building and maintaining these kind of cross-community provider partnerships. This, I just can't help myself but put this in as part of Reinvestment Act funds. We built an integrated resource center across the street from our health center. And it's a real great example, honestly, of 30 years of learning what it takes to serve people experiencing homelessness in a community-based setting with a primary care as the center model. And we used to operate this service, which is now 8,600 square feet for over 1,200 people in a much, 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 much smaller section of our building. So we're very excited about it. And in that building, we have a medical triage room. Even though it's just across the street, it is amazing at how often that gets used. And we have partners from throughout the community who come in and do in-reach in some one-on-one rooms on the bottom floor there. And the second floor is our complete case management and client advocate teams, who are often the people playing actual staff direct level service roles in these multi-system coordination. Sometimes there's some providers, but as you can imagine, they're on campus or doing outreach with other provider community organizations. So they play, our client advocates and social services play a huge role in the multi-system coordination from the direct staff perspective. Again, some of the things that we offer for both our partners coming to us and our ability going out to our partners, aside from the actual planning, implementation, and development of the multi-system coordination projects, is our outreach. Housing and engagement specialists are actually leaving the building and going out and doing VI SPDATs and other assessments to get people housed while actively living rough and on the streets. We have an Art Street program, which is an open studio art program, which again is a great place for our partners to come and actually meet with clients in a very low threshold, non-exam room setting. And then of course we do extensive collaboration, which is what we're here to talk about today. This is nothing new to you all, but I'll just point out that in collaboration with others has just been how we have always operated, and I think that's really important for today's conversation. So we have a multitude, as I mentioned, examples of multi-system coordination. They're all listed here. I'll go into details in over a few of them, but I will leave lots of time for questions. I think that's the most beneficial part of this webinar. We have been doing them back for at least over a decade now. However, what we do not yet have, which I can hear the richness in that from the Boston model, is actual data sharing. We do a lot through all of these multi-system coordination examples you'll see here. We do a ton of staffing and conversation and data sharing at the staff and coordination level, but we yet don't have electronic data sharing capacities, although I will tell you a ton of conversations, and I think we're really on the brink of some very exciting community-wide data sharing opportunities that would include all partners mentioned by Lauren. So Albuquerque Police Department, Albuquerque Fire Department, all health centers, UNM Hospital, our largest indigent care hospital, social service providers, HMIS, healthcare or homeless providers. So it's really, really exciting, and I'll talk a little more about where we are in that, but we actually are not sharing, except for, of course, our Homeless Management Information System, HMIS, is the most widely shared data sharing system we have right now. So the first one I want to talk about is our Pathways to a Healthy Bernalillo County. As you can see, this one started back in 2007 and went through a really intense participatory planning and development process that did not even culminate until January 2009. The reason I put this on the slide is because I just want to iterate over and over that these type of multi-system coordination projects take time, persistence, and patience, which are not always, I should say, they're never available. They're a very big luxury for the kind of work that we all do. So I will start with that none of them are as easy as they might seem on paper, and they've all taken a lot of cross-systems work and advocacy. At the end of this project, which is, as you can see now, is over just almost a decade old, Albuquerque Healthcare for the Homeless, we didn't even apply to get navigation funds in the first round. It was such an amazing coordination opportunity at that time. We felt it more important to sit back and not apply for the funds, but rather to see our partners throughout the community benefit from a navigator and a social determinants of health model. We eventually did apply about the second round 5 years into the project, and we have not applied for this third round. And that's just mostly, again, about our own internal capacity. But I wanted to say, to just point that out, that Albuquerque Healthcare for the Homeless doesn't always even benefit either financially or in any other resource, yet the resource investment on our end is always large and palpable, but important and exciting. Trying to change the slide here. Here we go. Albuquerque Healthcare for the Homeless Reentry Collaborative. This is one that we actually designed back in 2008, and I'll just talk a little bit about it as it was our own project, and we brought all the players to the table, which meant, because we aren't a huge healthcare system, we aren't a university hospital, it was a little harder to keep people's attention, and there was no data sharing outside of staffing and other one-on-one individual and some aggregate level post or respective data sharing. But it was an amazing project that served nearly 300 people with sometimes lifelong addictions to opiates who were exiting the criminal justice system. We saw amazing results with this partnership project. Again, just gave us the encouragement, like the Pathways program I discussed earlier, to continue to do these type of multi-system coordination. It has the highest impact on client outcome, and it is really, really useful in the multi-systems learning perspective. Everybody learned a lot how you do this and how you make sure that systems are coming together. So as this project, the Department of Health actually induced people on Suboxone for us, and then they would come to us for the treatment, and this is right after release from jail and or prison within the last 30 days. So everybody was checking in with everybody, and there were quarterly and biannual meetings that did deep dives into, like I said, where we were with aggregate level data, but nothing individual except for at the staffing level. So again, a really intense resource involvement as far as data goes, but high impact client level outcomes. Albuquerque Heading Home was an initiative that looked at a collective social impact model. We both were developers in it and benefactors of the project and the model. It was citywide collaboration. We had our mayor's support behind it, and it was funded initially by a SAMHSA demonstration grant, as was actually the reentry collaborative I spoke about on the slide previously. And it includes so many public, private, government, and nonprofit partners. Through this project, we have housed nearly 300 people over the last 6 years, and they're all medically vulnerable based on the VI-SPDAT. And as Mary was talking about in her project in Boston, we know that we are serving the most medically vulnerable because we have also lost at least 7 to 10 people within the first 6 months of housing them. But again, we know it's the best thing to do, and there are data sharing, but mostly it's not it's unidirectional. It's not going from us to them and back to us. So, and it's often in boardroom settings where we're saying this is what we see. So that data sharing capacity, I think, is really going to be a game changer for our community, and at least for our intense staffing compositions. I think it's really going to help us not have to be at so many tables all the time in such a large group, all the way from the provider level to, like myself, I'm the Director of Development Planning and Evaluation. I sit at these tables, I bring the aggregate data, I do the planning and development phases of it, and it takes a lot of time. Our Executive Director, sometimes our Finance Director, our Chief Health Officer, a lot of partners and parties have to come to these tables in order to make sure that these initiatives are data-driven without shared data processes. Community Connections is a housing, criminal justice, homeless service providers case management program that is also focused on housing people who are re-entering into the community after some time or multiple times in the jail system. And it's a great project that has really housed people right from jail to an apartment. Really exciting. We have housed probably about 200 people in this project over the last 3.5 years with only 2 other partners, including the county and city as a public and then private partnership model. Challenges with this have been really, really interesting, and we find the boundaries working with criminal justice and housing really, really interesting. We're looking at a housing first model. We just want to get people housed. The criminal justice system wants to make sure that there's no drug use in the apartment. They want, because it's a dual-funded project. So philosophies and fidelity to models, because they say they're a housing first model, is very, very interesting in this one, and we're constantly at the table discussing what housing first means and ultimately ending up taking a back seat to their philosophies because they're doing the funding of this one, and then we just do the best we can to provide case management through our healthcare for the homeless philosophy, but a lot of conversations, sometimes painful ones, about models. Again, with the lack of a shared data system, I think that adds to that challenge. We recently were funded as a community for the accountable health communities by the managed care systems, and we're one of 11 sites to receive a community health worker. So throughout our entire community, we have 12 community health workers looking at the social determinants of health. The aim is to screen 75,000 Medicaid enrollees for the 5 social determinants of health. As many of you on the call can imagine, these are the same we've been doing these screenings as a healthcare for the homeless for nearly 32 years. So we're really coming to the table as helping them figure out how do you ask about housing status, hunger, and the other social determinants of health we're looking at. So again, and this one will have a data sharing system, but mostly on referrals, not individual level. So super time intensive. We have to be at the table monthly and quarterly for advisory councils. Lots of great information. Everybody that Mary and Lauren have already, all the systems they have talked about and defined are at this table, and the other examples I've shown have all those same players at the table, but it requires so much staff intensity without the data sharing. That's exciting, and it's, for someone like myself, really fun to talk about and get our models out there, but it does not move as quickly as I would like, and as I think it could with some real data sharing potential. Another example that I think is really exciting, I'm just going to cover this last one. Oh, thank you. And then one little example of a very unique one, and then we'll go to the question and answers or whatever Lauren needs to do next. So I participated in a data-driven Justice Behavioral Health Design Institute, which was very, very unique and an opportunity sponsored by the Substance Abuse Mental Health Services Administration, Laura and John Arnold Foundation, and the Association of Counties. So there was a ton of technical assistance and support, really trying to get us to that level of data sharing. We participated with a cross-representative group of the leaders in these groups. So a congresswoman, our director of behavioral health services at the county level, an Institute of Social Research researcher, senior researcher, Deputy Chief of Police. You can see the names listed on there, so I won't bore you reading them all, but all that to say that I really think that our community is on the brink of some community-wide access to data sharing capacities. And as you can imagine, I put here some challenges, but they're none that no one has not already mentioned. But HIPAA, access to records, who owns the data, those conversations are intense and in-depth, and people get really, really heated and passionate about which way they want to go with that. And I will say, honestly, I think sometimes even we're much more conservative on the data sharing perspective, at least outside of our four walls, than even some of our partners. So some of the barriers are internal as well. Our county, Bernalillo County, is actually bringing in a whole day seminar with some attorneys from across our nation to help us figure out some of these data sharing challenges and honestly sometimes our own internal barriers to sharing data. These are just other examples of where that is happening that you've already heard about, so I'm not going to talk about those. And here I left this in here. While it's not a multi-system coordination from the care perspective, I thought it was a really great example of multi-system coordination from any perspective, right? So we just completed a project with the City 1% for the Arts, our University of New Mexico Department of Fine Arts. We created a mural on our building based on the Wall of Respect that came out of Chicago, I believe, in 1967, I want to say. It was a really interesting project that is really built around space and creating space and a place for people to congregate, including our police. We invite them to come in and get coffee, come to our health center and become a part of it, not just when there's a crisis or an emergency, but on an ongoing basis, and of course to make it more welcoming and inviting for the clients who are here, clients and staff, and our neighbors who are here on a day-to-day basis. So in order to do this mural project, we worked with students. It was funded by the city with approval of the City Arts Board. Our selection review committee included board, neighbors, representative staff on campus, our Art Street artists, social and racial justice advocates from across the community, and we used a scoring-based matrix that looked at, that actually scored and weighted the 7 groups of proposed mural projects based on whether they were from the community or not, and what that meant. Just again, all that to say that when you think about multi-system coordination and how you create responses to the needs of people experiencing homelessness, that we should think about our non-traditional partners and different ways that we can do that in addition to the care-based setting. So I think that's all I had on my slides, and I think we're just at the point of question and answer. Is that correct, Lauren?
Yes, we are. Thank you so much. I'm going to transition now into a time of facilitated discussion. This is just some questions that we put together to kind of dig a little bit deeper into what some of these multi-system coordination projects look like and how we kind of get that started in other communities. If folks on the line have questions, please remember to type those into the chat box, and we'll try to get to those in the next couple of minutes. So for Anita and Mary, some of the discussion we've talked about, you talked a little bit about kind of some of the background needs in your community and how some of those partnerships got started. But I didn't know if you wanted to talk a little bit more about that and really just kind of drive home, like, what convinced your organization to come to that table?
Mary, why don't you go ahead and start, and I'll come in at the end.
Sure. The partnerships among our consortium members predated me, but there were a number of reasons why we had been getting together for the years. There were things like we shared space with our partners. We would house our primary care clinics and a number of settings such as shelters or churches or other kinds of spaces. So we had this need to for that. There's also things like when a public health emergency would come up. Say we had a meningitis breakout just over a year or so ago, and we needed to be able to respond to that in a very quick way, and sharing information about who the patients were, or where they've been sleeping, and next of kin, and all that kind of thing. So there were those kinds of opportunities to collaborate. But then the real reason, as I had mentioned in the presentation, was this growing sense of worry about this changing delivery system. Massachusetts is really been focused on delivery system reform for a number of years. After they got everyone under the tent by expanding access to care, there was this need to, okay, what are we going to do to stem the rising costs? And so there was this worry that people would get squeezed, organizations would get squeezed out of the system. Long-standing community-based organizations would get squeezed out of this changing role because the ACOs would not have the inclination to partner with them. Unfortunately for Massachusetts, MassHealth got this right. They did require that ACOs partner with community partners. That's what they call the program. It's like a health home for those in other states. And they required that there's contract requirements that they must partner and provide complex care management through these community partners. So the idea is that we needed to kind of band together to get a really strong project with very deep capacity to care for the highest cost members in an ACO seemed like a value statement and a reason to get to convince people to talk about how we are going to work together in a new and improved way in this new marketplace.
This is Anita. So for us, as I think I described throughout, the need in the background, or the need for this kind of work in our community, it was well stated by Mary. I don't think we have any unique needs that weren't described. The reality is people need a lot of care, and with a lot of care we can help them end their homelessness, which is always why we came to the table. And the partnerships always got started really with the perspective of us talking to people and asking how can we do better, what can we do differently. We were a kind of late adopter Medicaid expansion state, so I think we learned a lot through our advocacy to push our governor to adopt Medicaid expansion, and through a lot of that work and of advocacy and systems-based frustrations about not being able to care for people in the way that we know we should be able to with the resources. That, I think, is the driving factor between why people keep coming to the table, and we've just known it's the right thing to do from a mission and vision-based perspective, and our executive director, Jennifer Metzler, has always just been go out and amplify our model and get people on board with helping people end their homelessness. So I think it's kind of been the way we have lived and breathed for many, many years.
Great, thank you. I think we've discussed a bit about kind of the different systems that you're working with and who's at the table, but I do want to ask, what types of agreements are in place? Do you have MOUs or other contractual agreements in place with your partners?
I can start out. We have, as I mentioned, we basically lawyered up. We used some grant funds to hire a lawyer to create what is called an organized healthcare arrangement, or an OCA. So that is a legal agreement that binds us together as a consortium. It puts in place guidelines for sharing PHI. It puts in place a governance, voting, all that kinds of arrangements. So it really gave us the ability to all kind of tread into this new arrangement with some feeling of that we are protected from in this new environment.
And yes, we definitely have memorandums of understanding, memorandums of agreements, business associate agreements, consortium agreements. We have so many agreements that when it's time for our operational site visit, we are often overwhelming our auditors with the number of agreements we have in place. And again, going back to that kind of system-wide data sharing, when we ever get there, as intimidating as it is for us at the stage of system-wide coordination that we're at, I think it's going to really minimize in the long run some of that work while maximizing our need to seek, we seek legal counsel and some kind of input on every single agreement we have to do. So at this rate, I think that we could definitely streamline it and maximize our impact by minimizing the number of agreements we have out there. Some of them are grant-driven agreements, some of them are shared services agreements, so it's pretty intense, and I really am looking for a way that we can streamline some of this, and hopeful that as our community steps up and gets more innovative, our lives in regards to the types of agreements we have to constantly be put in place, make sure they're up to date, make sure they address the accurate scope of work, as all of that changes very rapidly in today's world. So yes, it keeps us running.
Great, thank you. We did have a couple questions that came in, mostly around kind of data sharing and then thinking through that process. So one is, when you're sharing information via HMIS, is that information aggregated, or is it on the individual level? And if it's on the individual level, do you have releases indicating indicating who has access to that individual's information?
Yes, I'll go ahead and start with this one. We do have, I'm glad you said consents. We have, for all of these systems, we have sometimes multiple consents we're signing. So for HMIS is a great example. If they get care here in our health center, so at medical, dental, or behavioral health, they have to sign a consent form, and then they have to sign an additional one for our HMIS system. And that is often the case with many of our multi-system coordination initiatives. So I will say that again, any way we can, keep your fingers crossed for us that we can minimize that noise for our clients, because it's a lot. But as far as who has access to our HMIS system, it is both at the individual level and the aggregate level. So the way that works is, like, as Albuquerque Healthcare for the Homeless, we can see all of our clients' data, both individually and aggregately. And we can see some referral information, but we can't see our partners' data except for in the aggregate form, and usually in kind of a consortium or continuum of care kind of meeting setting.
And basically, what Anita said is about, as far as consents, we have a consent, patients had assigned a consent to get into the pilot. Basically, I will share my HIV status, STD, SUD information across these 10 partners. It wasn't a barrier. I thought that we would get a lot of no's. We got no no's. And I think that's particularly because we were using people, case managers that had already known the patients. They're teeing off of an existing relationship. So the consent was not a barrier. And we can see information like what our partners are doing. They can see what we are doing. They don't get a view of our EHR. We feed into the platform certain elements of our EHR that we think will be helpful, such as med list, upcoming appointments. That one's a game changer, and problem list. So it's a limited view of EHR data.
Great. Thank you both so much. We are coming up to the top of the hour, and so we're going to go ahead and start wrapping up. But again, Mary and Anita, thank you both so much for joining us today, and thank you all for being on the line with us for the last hour. I know we had a couple other questions come in, so I will make sure we follow up with those of you whose questions weren't answered. As soon as we finish up today, we will save this recording and be sending out the slide deck and the link to the recording as soon as those are ready to go out. If you're interested in learning more about working with the criminal justice system, we do have another webinar coming up, as well as a paper coming out, so stay tuned for more details on that. And then when you log out of today's event, you should see a survey pop up. Please fill that out. It gives us input so we can make sure that we're meeting your needs and expectations, and you can let us know if there are any other topics you'd like to discuss at a later date. And with that, CSH, as a reminder, is a national cooperative agreement with the Health Resources and Services Administration. If you would like any additional assistance, please reach out. And thank you all for joining us today. That will conclude our session.
Thanks, Lauren.